Hey, what's going on, guys? My name is Mike from Rescue Academy and Emergency Educational Institute. Today, I am doing something a little different. Today, I am reviewing some NREMT-P for the paramedic questions regarding respiratory management and airway management. If you are interested in joining future quizzes that I do, I'll be doing them live. And I will be letting everybody know. In the description below, I'll be adding an email. Just shoot me an email and just let me know that you're interested. Or if you have any questions, do so. I will get back to you. And I will create a list of people to add to these. So it's open to anybody. If you're interested, come on in. And so without further ado, this is going to be a review for your NREMT paramedic for airway management. First thing I'm going over is the actual exam itself. So unfortunately, I've had some talks with some previous students from the last class that I was teaching, and people are having a really hard time with this test. This test is extremely in-depth. And that's what's making it kind of challenging, because a lot of the material that you guys are grasping out of the book is great, and the stuff is going to work perfect when you get out in the field. But then when you try to take the exam, it's not going to be enough. Okay, they're going pretty far and beyond. So let's talk a little bit about this test first. First thing I want to talk about is that this exam is an adaptive test. Now, what I mean by an adaptive test is that depending on how well you do, the test is going to change. So for example, let's say you're a badass at airway and you get an airway question. You get it right. They're going to give you, out of a certain amount of questions that are going to be airway, they're going to be easy, probably EMT questions. You get them right, they're going to become a little bit harder. You get those right, they're going to give you another small group that's going to be a little bit more challenging. And they're going to keep doing that until you reach the national standard that they want the paramedics to be and a little bit above. And if you pass the ones that are a little bit above, or at least the standard, they're going to move on to the next section. Now, right here, this is on the actual NREMT website. You're going to have a total of 80 to 150 questions on this exam. Now, understand that only 60 to 130 of these questions are going to be considered live questions. And what that means is that these are the only ones that are going to count towards your final score, meaning there's going to be 20 pilot questions. Those 20 pilot questions are actually questions that aren't graded, but you are not going to know which questions those are. Okay, it's going to be completely random, and you're just going to be taking the test, and hopefully those 20 pilot questions aren't questions that you smoke and the other ones you fail. This is how your test is broken up. Right here we have airway, respirations, and ventilations, which we are going to be going over today, and that is 18 to 22% of your grade. So 20% of it is going to be airway. Now, don't stress about peds as much as a lot of people do stress about peds. Why? Because it's only going to be 15% of your exam. So 15% of the total exam is going to be pediatrics. 85% is going to be the adults. Kind of, just because up to 14% is going to be EMS operations. So that's not going to have to do kind of like with either, but note that they're going to have a lot more adult questions than peds. For cardiology, they're going to have 22 to 26%. Trauma is going to be 13 to 17%. Medical and OB is going to be 25 to 29%. So that is going to be the most out of everything inside of this exam. Now, don't think that that means that it's going to be just a bunch of OB questions, because it also includes medical. So when we start talking about medical, that can be a huge range of topics. When we start talking about anaphylaxis and just those type of medical emergencies, it could be a lot of different other things, toxicology and things of that sort. So understand there's going to be a lot of different types of questions, and this is exactly how they're percentaged. Now, another thing I want you guys to know is you have a total of 6 opportunities. How it works is you get a total of 3 tries, 3 initial attempts. After that 3rd attempt, you have to go, like it states, a candidate must submit the official documentation verifying completion of remedial training. So you need to go get remedial training, and it has to be from a CAPAS course. Now, the CAPCE stands for, right here, Commission on Accreditation for Pre-Hospital Continuing Education. Okay, this website that I'm on right now is CECBEMS.org, and they show a ton of different classes that you can come and find, and they're just small continuing educational hours that go towards your remedial training that's required. Another thing I want to point out, if you're not practicing now, you're messing up. And I'm going to tell you that right now, because a lot of people, what they're doing, and I'm noticing, is that they're getting out of paramedic school and then they start practicing for this exam. It's problematic because you start forgetting about some of the past stuff, and near the end of your schooling, you're going to start feeling like you're over it. Just start practicing now on these exams. If you've never looked at our JB Learning, this is what it looks like. Up here at the top, this test prep right here, this is how you can access some national registry type questions. And this thing is awesome if you open this up. Helps out a lot. What you do is you would obviously log in as a student. This is what your view would look like. You would create a new practice exam. And for example, airway and breathing, there's 115 total questions that they're offering that are similar to the NREMT-P. You could type in all 115 here, or if time doesn't permit, you could go ahead and type in 20, you hit add, and now we got a 20 question exam down here that's ready to roll. And not only does it allow you to take the exam, but it also breaks down exactly what is going on in that question. It breaks down the question, why you got it wrong or why you got it right. All right, so please, please, please use this test prep. It's going to be awesome. So if you are not playing, I'm going to go ahead and read out these questions and answers. So when visualizing the vocal cords with a Mac blade, you should A, place the blade under the epiglottis and lift with a handle. B, place the blade in the left side of the mouth and sweep to the right. C, place the tip of the blade in the vallecula, lift the jaw and blade gently. Or D, place the blade in the middle of the mouth and pry back. So remember, with the Mac blade, we got 2 different blades. So we have a Mac blade and we have the Miller blade. The Mac blade goes into the vallecular space. So the vallecula is located, if you see the epiglottis, you're going to place the blade just above the epiglottis and then lift up and out in a 45-degree angle. Remember, it's like cheering a glass. You don't actually want to place, like it says in letter A, place the blade under the epiglottis. Remember, we're putting our blade above the epiglottis. That is the vallecular space, and we're going to displace. Now, whenever we're using that Miller blade is the one that's actually going to be placed just under the epiglottis, and you're actually going to lift the epiglottis with the blade itself. Why was B incorrect? We don't place the blade in the left side of the mouth. We place the blade from right to left, okay? Not left to right. And D was incorrect because you don't place the blade in the middle of the mouth. Remember, we want to go ahead and sweep, and we never pry. All right, and everybody saw that that was an incorrect answer. While ventilating a patient in cardiac arrest, what end-tidal CO2 reading indicates return of spontaneous circulation, or ROSC? Is it A, a steady decrease in end-tidal, B, no end-tidal CO2 reading, C, an abrupt and sustained decrease in end-tidal CO2, or D, an abrupt and sustained increase in end-tidal CO2? Which one shows ROSC? The answer was D. So when you're ventilating a patient and the patient's in cardiac arrest, that's a nice part about end-tidal capnography. End-tidal capnography, what reading should it be during CPR? Good, Nate. So it should be above 10. All right. We know it should be above 10. Now, if we see 12, 12, 12, 12, 12, then all of a sudden we see 38, we see 40. That's usually indicative of ROSC. All right. So sometimes you can go ahead and just say, hey, let's stop. Let's go in and check a pulse. Now, technically, are we supposed to wait for 2 minutes before we check a pulse? Absolutely. But understand that if you see an abrupt increase in end-tidal CO2, typically that means your patient's breathing. All right. And your patient can't be breathing if they don't have a pulse. That's why it shows ROSC. Your patient is unresponsive. You notice severe upper airway obstruction caused by a piece of steak. What do? A, position the airway. B, perform chest compressions. C, reattempt to ventilate the patient. Or D, perform a blind finger sweep. All right. Wow. Did people really say perform a blind finger sweep? We never perform a blind finger sweep. Ever. All right. So I always thought people were going to pick A, reposition the airway. Now, remember, your patient, there's a couple key terms that you need to note whenever talking about foreign body airway obstruction. The first being up here, unresponsive. All right. So right away, we know that we're not going to be performing the Heimlich maneuver or abdominal thrust. Then it says, you note there's a severe upper airway obstruction. To note that there's a severe upper airway obstruction, severe, that means that you've attempted to ventilate. All right. If you already attempted to ventilate, you know that this patient is obviously choking. It's so much that they went unresponsive. You're going to start chest compressions. All right. So remember, we go straight to chest compressions and try to relieve that choking. All right. Number 5, which of the following is correct regarding the concentration of gases? A, the partial pressure of oxygen is 21% in hemoglobin. B, atmospheric air contains 24 to 28% oxygen. C, nitrogen contains about 79% of the atmospheric air. Or D, about 15% of gas within the alveoli is carbon dioxide. Which of the following is correct regarding gas? Wow. So a lot of people went for A. I thought that was going to trick people. Partial pressure of oxygen in hemoglobin. All right, let's talk about it. So the amount of oxygen that's in the atmospheric air is about 21%, okay? 20.8% technically, okay? Nitrogen is about 78, 79% in atmospheric air, all right? And the other 1-point-something% is gonna be other gases. Now, partial pressure of oxygen in the alveoli is approximately 104 millimeters of mercury, all right? Whenever we start talking about partial pressure, it's not percentage, okay? Whenever you hear the word pressure, you're thinking millimeters of mercury, all right? So you should have known that that question or that answer A was incorrect, all right? The percentage of alveolar carbon dioxide, all right, here for D, the real answer is about 5%, okay? 5% of alveolar carbon dioxide is there. And just remember, be very mindful when they start talking about 21% of oxygen. That's in atmospheric air only. Your 72-year-old patient has an acute onset of dyspnea. Which condition is least likely to be the cause? A, pneumothorax. B, pneumonia. C, pulmonary embolism. Or D, hyperventilation. Acute onset of dyspnea. Acute. All right. Wow. All right, let's talk about it. So we're talking about acute onset of dyspnea. Acute onset of shortness of breath. We know it's not A, right? A causes is obviously you're going to have an acute onset. You got traumatic injury. It could be from a sneeze, you know, depending on the person. Now, pneumo is going to cause an acute onset of shortness of breath. Pulmonary embolism. The embolism itself isn't acute, but the pulmonary embolism and dyspnea is going to be acute. All right. Hyperventilation just means someone's breathing fast. That could be done acutely. The only thing that takes a while before it becomes shortness of breath is pneumonia. It's an intrapulmonary infection. This typically presents with a productive cough, fever, and chills. Respiratory distress with pneumonia gradually worsens with time. Hyperventilation, pulmonary embolism, and pneumothorax are all considered acute respiratory dyspnea. Now, what kind of patient do you think gets pneumonia? What kind of patient are you thinking? All right, it says old. Definitely older patients are more likely to, okay? But understand that these patients aren't just old, they're sedentary, all right? Patients who are in a nursing home, patients who don't move around. Believe it or not, I believe the most common cause of pneumonia is actually strep, all right? Patients that get strep and they're older, bedridden, they are highly likely to get pneumonia. Now, one thing to always note with pneumonia patients is you kind of always want to ask, have you had a cough recently? Have you been sick recently? Always check a temperature, but don't think that every patient is going to have a temperature at that point. Just because they have a pneumonia, they could have had pneumonia for, you know, days, weeks. So they might not have a temperature right now. Question number 7. What is the Hering-Breuer reflex? Is it A, terminates the inspiration to prevent overexpansion of the lungs? B, signals to increase the respiratory rate? C, it is responsible for setting a resting respiratory rate? Or D, it triggers the patient to cough when there's a foreign body present? All right, nobody got that one. A little harder. All right. Now I put this one in there because this is a type of question that is a little out there. All right, but it's in the book. It's actually an anatomy. All right, I have it here on page 372, which does pertain to respiratory. All right. Now, basically, what it is, I'll read it to you. There's something called mechanoreceptors, which are located in the smooth muscles of the bronchi and bronchioles and the visceral pleura. Now, remember that visceral pleura is what's surrounding the lungs. When the lungs inflate, these stretch receptors are stimulated and nerve signals are sent to the respiratory centers by the vagus nerves to stop inspiration. Okay, so this happens when your lungs expand. It sends out a nerve impulse to actually say, hey, let's stop breathing. This reflex is called Hering-Breuer reflex. It's designed to prevent overinflation of your lungs in a conscious, spontaneous breathing person. Jocelyn's in the lead. Which of the following patients would you treat with a CPAP? This is a good one. Would you treat the 80-year-old male that's unresponsive with slow, irregular breathing? Would you treat the 28-year-old female that is wheezing with an SpO2 of 95%? C, 67-year-old male and severe respiratory stress with rales with a respiratory rate of 6? Or D, 84-year-old female and severe respiratory distress with rales with a respiration rate of 24? All right. Somebody saw rales and jumped on it. Be mindful. What patient is getting the CPAP? What are some contraindications for CPAP? Let's talk about this. CPAP, non-invasive form of positive pressure ventilation, used for CHF with pulmonary edema. Okay, it's CPAP transmits positive pressure to the lower airways, which it forces air into the alveoli, re-expands these alveoli, and opens the bronchioles. Now, CPAP has been shown to reduce the need for intubation and often causes rapid improvement in the patient's clinical status. CPAP is contraindicated in patients who are unable to follow commands and those who are hypoventilating. Okay, if a patient has hypotension, hypoventilation, or low respiratory rate, we are not going to be giving this to that patient. Now, the big thing here was seeing that this patient had a respiratory rate of 6. Remember, you're going to be giving this to those patients that are having shortness of breath. They're able to follow commands and they're breathing at a normal rate. If someone's breathing at 6 times per minute, they're going into what's known as respiratory failure, and that's when this is contraindicated. Those are those patients that we're going to be intubating. Number 9, what is the process called when O2 and CO2 are exchanged between inspired air and the pulmonary capillaries? Is it A, internal respirations, B, diffusion, C, pulmonary ventilation, or D, external respiration? What is the process called when oxygen and carbon dioxide are exchanged between inspired air and pulmonary capillaries? Damn, nobody got it. All right, so let's talk about this. Respiration. What is respiration? It's defined as the exchange of oxygen and carbon dioxide between the body and its environment. Okay, so obviously breathing, we breathe air, and that air goes into our bodies. External respiration is when that exchange of oxygen and carbon dioxide between inspired air goes into our pulmonary capillaries. This is also known as pulmonary respirations. And internal respirations, which is the other part of it. Internal respiration is the transfer of oxygen and carbon dioxide on a cellular level, okay? Well, it's between capillaries and tissues known as cellular respiration. All right. Pulmonary ventilation is defined as the movement of air into the lungs. That's it. So one person picked pulmonary. Pulmonary ventilation, movement of air into the lungs. Diffusion, remember, is the process of particles moving from one area of higher concentration to an area of lower concentration. That's all it means. That's all diffusion is. All right. Just remember, if you see external or internal respiration, let me say it again. External respiration is the exchange of oxygen and carbon dioxide between inspired air and the pulmonary capillaries. This is known as pulmonary respirations. Internal respirations is the transfer of oxygen and carbon dioxide, and that is carbon dioxide between the capillaries and tissues, and this is known as cellular respirations. What's the best way to ventilate an adult patient who has a stoma but has no tracheostomy tube? So they have a stoma, no tracheostomy tube. Now we got to bag them. Attach an infant or pediatric mask to an adult BVM and seal over the stoma. Perform a head tilt chin lift and provide ventilations. Wow, that one was quick. And the last two are ventilate the patient with a pediatric BVM. And the last one was intubate the patient immediately. Now, most people got it right. You attach a pediatric BVM mask to the actual adult BVM. Somebody chose pick ventilate with a pediatric mask. Remember, you're still ventilating an adult. You still have an adult patient. So we're not going to pick a different size BVM. We're still going to use the adult size BVM, but we want to use the pediatric mask to actually get a good seal around the stoma. You don't want to use an adult seal because it's going to be too large. You're not going to get a good seal. Your 9-year-old patient's acting lethargic. Vitals, 82/62. Pulse is 98. Respirations are 10. SpO2 is 86%. What's your first intervention? All right. Wow. We got people saying rapid transport, manage the patient en route, and apply a non-rebreather. Let's talk about this one. So we have a 9-year-old girl. She's acting lethargic. Acting lethargic, not acting right, confused, altered mental status. The biggest vital sign that I want you guys to note is right here. All right. The average ventilation rate for a child in our chapter that we just read was 12 to 37. Up to 37 respirations a minute is considered normal. This kid was breathing 10 times a minute with a pulse ox of 86 and was altered mental status. Be mindful. If someone's lethargic, do you think hypoxia can cause that? Absolutely. All right. So don't think that you're going to jump to a non-rebreather first. The first intervention that we're going to go straight to with this small kid that's lethargic and barely breathing, we're going to start bagging them immediately. All right. Be mindful in these questions on your NREMT-P. It's not going to look like this. All right. And the reason why I say that is look how short this question is. They're going to give you a whole paragraph. And in that paragraph, there's going to be some meat to it. All right. A lot of it's going to be fluff, but the meat to it is going to be right here. They're going to give you some vital signs. Those vital signs are going to dictate how you treat. Be mindful that especially if it's a pediatric, know what the vital signs should be. And then that's going to kind of dictate, is this really abnormal? Is this something I need to treat right now? Or can we do something less invasive like a nasal cannula or a non-rebreather? We're not going to just go rapid transport. All right. We got to intervene right then and there. Number 12, your patient's unconscious and snoring. His wife states that she thinks she gave him too much insulin. What are we going to do? A, open the airway, oxygen, Narcan intranasal. B, open the airway, oxygen, oral glucose by mouth. C, open the airway, oxygen, dextrose IV push. Or D, open the airway, oxygen, glucagon intramuscular. Too much insulin. So let's talk about this one. Our patient's unresponsive, all right? Unconscious and snoring. The second I see snoring in any type of question, the first thing I'm thinking is the head, tail, chin lift, all right? And so should you. First thing we need to think about is airway. So immediately, especially if it says what's your first thing that you're going to do, if safety's not something that I'm seeing, I'm going to go for some sort of opening the airway. But now it says his wife states that she thinks she gave him too much insulin. Now, what does insulin actually do? Insulin allows for the glucose to get into the cell, right? So if someone takes too much insulin, their sugar goes down, all right? It absorbs all that glucose that's in the blood. So if somebody takes too much insulin and they're unresponsive, we know that we need to give them some sort of glucose. Now, why can't we give them oral glucose? Because they are unconscious, okay? So then why can't we just give them glucagon IM? All right, we can, but what's the best route? If we have dextrose IV push, that is always going to be your best route, all right? The reason why we're not giving Narcan is this question gives no indication that the patient was on any type of opioid. Now, if you can't find anything else, if you check the sugar and you can't find any other cause, is it contraindicated to give Narcan? No, absolutely not. You can attempt giving Narcan, but understand that we are going to only give glucagon if we can't get the actual IV, right? So Narcan, no, is not going to be considered your last resort. Remember, we're going to be giving Narcan if we find pinpoint pupils or if we can't technically, if the sugar's fine, I don't see any head trauma, I'm not thinking anything else, and I'm not sure, we can use Narcan kind of as a diagnostic tool. But if I can get a line, dextrose is always going to be your answer. If we can't get the line, that's when we're going to go for the glucagon, okay? Nothing here said if we had an IV established. If this question took a different route and says you attempt an IV 3 times and were unsuccessful due to poor vascular access or whatever it says, then you would have picked the glucagon IM. Next question. Which of these medications would you use to raise blood pressure by stimulating sympathomimetic dopaminergic receptors? Is it A, epi, B, dopamine, C, Versed, D, Lasix? Is it a trick question? No, there ain't no trick here. Too easy, right? All right, good. Dopamine. Understand that what dopamine does, like epinephrine, both technically vasopressors, right? Understand that there's 3 different categories that dopamine works for. Lower dose dopamine, and it's going to have renal effects, all right, which is going to be dilation of the kidneys. When you get a little bit higher than 5 and up, is typically going to start your chronotropic, inotropic, dromotropic, which is going to increase your heart rate and blood pressure. Once you start getting around 15 and up, that's when you're going to start causing that alpha effect, all right, and actually causing vasoconstriction. So remember, giving dopamine, typically from 5 to 15, you're going to be increasing heart rate. Higher than that, you are going to be causing vasoconstriction, and lower than 5, you're going to be dilating renal, all right? You're dilating kidneys. Number 14, which is not a cause of hypoventilation? Which is not a cause of hypoventilation? Is it A, increased altitude, B, impaired ability of lung expansion, C, decreased neurologic function, D, foreign body airway obstruction? Which is not a cause of hypoventilation? Gotcha, guys. All right, hypoventilation. So what is hypoventilation? Slow breathing, right? Everything in here can cause slow breathing except for one. And it is A, increased altitude. What does an increased altitude actually do? It makes you breathe quicker, right? Because of the pressure change, all right, you have a decrease in barometric pressure. That decrease in barometric pressure makes it harder for that gas exchange to occur, which causes your body to breathe more, all right? That's why you are short of breath when you go into the mountains and you do a little bit of work, all right? So it would not cause hypoventilation. It would actually cause hyperventilation. Be very careful on questions like this. Number 15, a breathing pattern characterized as having an irregular pattern, rate, and depth with intermittent patterns of apnea. Is it A, Biot's, B, ataxic, C, agonal, or D, Shane-Stokes respirations? Breathing pattern, irregular, in depth with intermittent patterns. All right, let's talk about this. All right, this is exactly what I thought I'd see, and it's the wording that you need to get in your head, the difference between Biot's and Shane-Stokes. Now, I'm glad that nobody else picked ataxic or agonal. All right, let me talk about those real quick. Ataxia just means like bad balance, okay? So nobody went for that. Agonal respirations, slow breathing, all right, or gasps that are typically really wide apart. Typically, you'll see that in cardiac arrest or in the beginning of cardiac arrest. Now, Biot's respiration is completely erratic, right? Now, what this says is it's a breathing pattern that is irregular, an irregular pattern, irregular rate, and depth with intermittent patterns of apnea. Does anything in this question sound regular at all? No, absolutely not. Everything it's crazy, all right? So we have an irregular pattern, irregular rate, and depth with irregular patterns of apnea. So nothing in there actually sounds like it has any regularity to it. Now let's talk about Shane-Stokes. Right here in your book, Airway Management, Chapter 15, page 785. We have Shane Stokes respirations, which gradually increases rate and depth of respiration. So it gradually increases, increase, followed by a gradual decrease. So now the respirations are decreasing with intermittent periods of apnea. Okay, so that's what Shane Stokes is. Shane Stokes, you're going to see someone breathing, they're going to ramp up, they're going to start breathing fast, they're going to start slowing it down, and then they're going to have periods of apnea. And then that's going to happen all over again. So it's more of a pattern with Shane Stokes. You're going to see it go up and down, stop, up and down and stop. With BIATS, it's completely irregular. Be careful with that in your test questions, because I can almost guarantee that you're going to see a question like this on your exam. Number 16, your 70-year-old patient is having shortness of breath with wheezing in all fields. You decide to give mag sulfate. What is the dose? Is it A, 1 to 2 milligrams over 15 minutes? B, 1 to 2 grams over 2 minutes? C, 1 to 2 grams over 15 minutes? Or is it D, 1 to 2 milligrams over 2 minutes? Oh. So we got actually a couple people that got it right. 1 to 2 grams over 15 minutes. Now, if you guys have not seen the latest video I put out on YouTube, I put out a video on mag sulfate, not only talking about mag sulfate, but I actually draw it up and I actually put it in the bag and I flow the drip and I do all that. So take a look at it if you haven't seen it. Mag sulfate, believe it or not, is an electrolyte. Okay, so magnesium, everybody has it in their body. It's an electrolyte that you have. And now it has some properties that we utilize in the pre-hospital setting. One being anti-inflammatory and another being smooth muscle relaxation. Now, whenever we use it for shortness of breath, now this one said we use it for a patient with wheezing. We're going to be giving this medication after we give a beta-2 agonist. So we've already given our Atrovent, we've already given our albuterol, we might have even given our epinephrine already. We are going to be giving this mag sulfate as a drip over 15 minutes, and it's 2 grams. Now, one thing that I can tell you, one thing that helps me always is saying everybody gets 2. So if I say that, if you're having shortness of breath, you get 2. But if you're pregnant and you're seizing, not only is it you, but you also have your baby, now it's 4. Remember, everybody gets 2. So you get 4 grams if you have a baby, and somebody who's in torsades or somebody who's having shortness of breath, hypomagnesia, you're going to be getting 2 grams. Another one that a lot of people like to use is the syllable trick. Asthma, 2. Eclampsia, 4. All right, that's another trick. So you got 2 grams and you got 4 grams. Remember, this medication is not given in milligrams, so do not pick milligrams. I put that there just to trick you guys. Number 17, what is the main goal in administering epinephrine for asthma? What's the main goal? A, bronchodilation by stimulating beta-2 receptors. B, smooth muscle relaxation by stimulating beta-1 receptors. C, bronchodilation by stimulating alpha receptors. Or D, vasoconstriction by stimulating alpha receptors. You got to know the difference between beta and alpha on this. Remember, beta-2, right? Beta-1, we got 1 heart. Beta-2, you got 2 lungs. And remember, alpha, we're talking about arteries and blood vessels. So this is bronchodilation with beta-2. All right, and that's why epinephrine can still be utilized in asthma, because it has those beta-2 properties, and we can actually cause that bronchodilation. That's why you're hearing wheezing, because there's so much bronchoconstriction going on. Now, the breathing pattern characterized by hyperpnea, I hate that word, and tachypnea is also known as A, Kussmaul breathing, B, obstructed breathing, C, Biot's respirations, or D, Shane-Stokes respiration. So really fast and really deep breathing. That's what you got to look at this as. Good. Kussmaul respirations. Now, with Kussmaul respirations, the patient takes really big breaths, and what they're blowing off is ketones. Okay. This patient is in diabetic ketoacidosis, also known as DKA. All right. Kussmaul breathing is characterized by periods of increased rate of depth. It's most often seen in metabolic acidosis. So patients that are acidotic and they're trying to blow off that CO2. Remember, your body is always trying to maintain a balance, right? Your body's always trying to maintain that balance. And by doing so, it can cause Kussmaul respirations. So let's talk about end-tidal real quick. With this being said, if my patient is considered acidotic, would my end-tidal CO2 be high or low? Our patient that is acidotic is going to have a high end-tidal CO2. Remember, the retaining CO2. They're not breathing. They retain it. It keeps going up. Their pH drops. So it's the opposite. Here's my next question for you. If my patient's acidotic, what's my patient's pH level? We're talking pH, not end-tidal CO2. Remember, end-tidal CO2 is a range from 35 to 45, right? You all said if my patient's acidotic, it's considered low, which you're right. It's going to be under 35. Now, pH, a normal pH level, which you have to know this, a normal pH level is anywhere from 7.35 to 7.45. It's considered normal. So anything that's below that is considered acidotic. It's got to be lower than 7.35 is considered acidotic. Now understand, if your patient's pH falls below 7, your patient could actually go into a coma. So what's it called if my pH is high? Above 7.45. Alkalosis. Good. So my patient is alkalotic if my pH is above 7.45. If it rises above 7.8, it causes what's known as uncontrollable, sustained skeletal muscle contractions. Now, be mindful that those patients are hyperventilating, right? All right. And if your patient's blowing off too much CO2, your patient can become alkalotic. And when your patient becomes alkalotic, their pH is going to be above 7.45, and that's when it can cause those muscle contractions and they actually tense up. Which infectious disease is most common cause of pneumonia in the US for children under the age of 1? Is it A, RSV, B, TB, C, pertussis, or C, rubella? RSV is actually the answer. Now, RSV, also known as respiratory syncytial virus, RSV, I always just call it RSV, virus that infects infants, airways, and lungs, okay? Fairly mild in adults, but it's typically caused in children and infants, okay? Primarily seen during like winter time, all right? Usually in the colder months. This is the most common cause of pneumonia in kids. Now, like we talked about pneumonia a little bit earlier, it's typically seen in older adults that are sedentary. But RSV, remember that's actually the #1 cause of it in small children. Last question. What is the role of surfactant within the lungs? What is the role of surfactant? Does it protect your lungs from an infection? Does it B, lubricate your lungs to expand? C, reduces surface tension inside the alveoli to keep the alveoli open? Or D, strengthens your lungs from collapsing? I know everyone's heard it before. Good job. So it's C. Right out of your book. All right. I got it right here on page 363. there's cells that are in the alveolus and your alveoli, all right, that produce this substance known as surfactant. It reduces surface tension and helps keep the alveoli open. When alveoli are damaged by an infection, cigarette smoking, or other trauma, their ability to repair themselves, all right, correlates with these cells. Now, if these cells are destroyed or damaged, the alveolus cannot make new cells or surfactant, and it's dead. And the cell or the alveolus or alveoli collapses. All right. And the reason why these alveoli need to keep inflated is this is how respiratory exchange of oxygen and carbon dioxide occurs, right? So respiratory exchange between the lung and blood vessels occur in these alveoli when they are expanded. Surfactant is a substance that just assists in keeping this open. Hey guys, I hope this video helped. As always, if you have any questions, please feel free to ask in the description below. I'm going to be adding my email. If you are interested in joining us for any of the future quizzes or reviews, I'm going to be doing EMT and paramedic. So please shoot me an email and I'll add you to a contact list. But just let me know, be specific that you either want paramedic or you want the EMT, and I will make sure to send you an email. All right, so if again, like, subscribe, and I'll see you guys next time.